So we first started doing these experiments at the beginning of the pandemic. The idea of sneezes and coughs and just talking might communicate or transmit the disease was something which was being discussed, and we couldn't quite understand the evidence for that. There's a simple O2 mask which is used to treat people who have shortness of breath. The nasal cannula is also used to treat people who are having shortness of breath with assistance from oxygen. And the question was, when these things are spewing oxygen, are they spreading more aerosols which are being exhaled out? Is it more than when we are regularly breathing, talking? How does it compare if they are oxygenating at a higher rate versus lower rate? How does it compare in a closed room versus a ventilated room? Surprisingly, there's no systematic study of that.
So basically, we have a mechanical lung which simulates human breathing, and we have hooked it up to a CPR dummy. It breathes as a normal person would. We control it with a ventilator, so you can change the settings. Fog is sucked inside the mechanical lung, and then it is exhaled through the mouth or nose. And this setup is used to track aerosols expelled from our body during breathing.
We track the puffs individually through the frames. Once we have those frames set up and we know the start and the stop of each exhalation breath, we see how far it goes without the mask. We're able to analyze how far it's gone and roughly the intensity. With the surgical mask, we found that some of these exhalations are redirected from the vicinity of a patient lying down flat or sitting up in their hospital bed. This works to maintain a space for healthcare workers, and that's the whole point.
So we not only illustrated the problem, but we came up with a solution, which can be carried out everywhere across the world with the surgical mask technique that we are proposing.